first it was Shane Retty, the health minister, but then it was Simeon Brown saying that they've hired, thousands of nurses and record funding, and at times they've said there's overstaffing.
Just an example. This is a genuine example, but I can't when that was. But I know one particular week there were 80 nursing vacancies across Northland to Fataora. And they are only allowed, and this is not coming from our general director, it's coming from a national level, they are only allowed to approve and advertise 2 per week. So there are numerous educators, senior nurse roles, floor nurses not even being advertised.
Welcome to another episode of The Frontline. Thank you for joining me. I'm Dr. Gary Payenda, and today we're going to be speaking with Rachel Thorn. Rachel is an emergency department nurse, a representative of the New Zealand Nurses Organization, a member of that group, and a delegate in their negotiations with Health New Zealand. She's well experienced with frontline care, and I think it'll be an interesting conversation for listeners. You don't often hear the point of view of a nurse who's allowed to tell you their real life situation, the situation on the ground, to speak for half an hour or an hour. And it was a good chance for me to ask the questions that I've been wondering about for a long time. You obviously, in the regular media, mainstream media, get a certain view of the nurse management debate. And so it'll be a good chance for us to hear from the other side, the side that's not so often represented. And we're going to hear about some facts about understaffing, chronic shortages, things like mandatory overtime, and she'll address hiring freezes that are highly debated by management and Health New Zealand, saying there is no hiring freeze. Other frontline healthcare practitioners saying absolutely there's a hiring freeze and an inability to hire new staff, or in many cases even to advertise for the job. So it's interesting to see how this talk plays out, and I hope you find it enjoyable. If you do like the show and you want to see more of this sort of thing, please comment, put a like up, and subscribe. And if you find this valuable, I'll try to do more of it in the future. Sit back, relax, and enjoy The Frontline. Hi, Rachel. Thanks for joining us on The Frontline. Can you go ahead and introduce yourself for everyone out there, all 2 or 3 people that are listening?
Yeah, sure. Yeah. I'm Rachel Thorn. I work in Whangarei ED. I'm one of the ACNMs there. I'm an RN on the floor and I coordinate. I'm also one of the NZNO delegates for the area and the Northland convener, co-convener with one of the other ED delegates. I am also currently on the bargaining team for the employment contract.
Okay, that's a lot of titles. NZNO is New Zealand Nurses Organization, right?
New Zealand Nurses Organization,
the union for nurses, basically. Is that right?
The biggest union for nurses, for most nurses.
And so you are helping them negotiate contracts or potential contracts right now. Is that right?
Yeah, we're renegotiating our contract. It usually comes up every 2 or 3 years. There's 10 of us selected from around the country to represent the 32 or however many thousand nurses, and we are in the room with Te Whatuora to negotiate the next contract.
Can I ask you a few questions about that process? And I realize that you can't tell me anything that's sort of secret and privileged, but I just want some general info because I think the public would love to know sort of how this whole process works. So every few years you renegotiate a contract, and how have the negotiations been going so far this time around? First of all, when did the negotiations begin, and where are we in them?
So the contract was due to finish in October last year, and we initiated negotiations in September. So we have been in the room 16 times with Te Whatu Ora since September last year. And to be honest, we really haven't got very far. There hasn't been a lot offered, either monetarily or otherwise. We've made some small headway, but they have been absolutely staunch on their pay offer, which has been 1%. They don't want to do back pay, and as of now, obviously the contract's finished, so they don't want to back pay any increases to when the contract finished. They have offered some small tokens around enrolled nurse pay, which is great, and nursing practitioner education support, which is great, but nothing for senior nurses, nothing for pretty much everything. There's 40 claims, so very little has been offered. And we haven't been able to make any headway. They haven't been willing to go back to the government to request any more money. And we've had both mediation and facilitation to try and move the bargaining forward, and that has been unsuccessful.
Just to talk for a second about what they've done right in these negotiations. What are some of the things that you see as being positive? Because we'll talk more about the problems in a second. Sure. But just to be fair, what things are they on the right track on?
I think they've certainly listened to the discrepancies with the nurse practitioner educational support, and they've taken that on board, and they are willing to support that being consistent across the country. They have listened to the changes for the enrolled nurses, meaning that the enrolled nurses will have a wider scope of practice, and they've acknowledged that needs some kind of financial remuneration, and they have made an offer on that, which is probably not exactly what was requested, but it's a decent compromise. They have offered to put in a clause which supports a tikanga allowance for people who are doing the work to integrate Te Ao Māori into the workplace, which is great. It's not as comprehensive as we would have liked, but it's a start. So they're basically matching what's currently in the PSA union contract. So that's a start. It's not the end, but it's a start. Yeah.
So the doctors are also facing contract negotiations now and doing rolling strikes around the country, sort of region by region. I think Te Tai Tokerau is June 18th, starting at 10 a.m. One of the things we emphasize is that there are a couple aspects to this. One is financial remuneration. So we're very uncompetitively paid compared to, let's say, Australia, probably 40% less. But a big part of it is working conditions. So like for me personally, just speaking on my own behalf, the pay issue is not as bad as the fact that so many shifts are understaffed and underfilled, and not enough doctors. So we know nationally there's like 15% approximately understaffing of doctors, but in some areas it could be up as high as 43, 44%. And if you can imagine what it's like to work in a department like that, it's really bad for patients, and it's bad for the remaining staff, and then they get burnt out. What is the nursing situation regarding understaffing specifically? Because you hear a lot of different things in the media and from the politicians. So how is the nurse understaffing issue?
I think the understaffing is one of the main issues, and that's unsafe staffing has been a big part of our claims in this bargaining. I think Te Whatu Ora would say that they are supportive of our safe staffing, and that they are still doing the work to enable safe staffing. That's actually not true, because we got some information last year through the Information Act, through the Official Information Act, which showed that in 2023, a quarter of shifts across the country were understaffed. So after that, so that was in 2023, and then last year, about this time last year, they decided they were going to put a pause on recruitment, which obviously wasn't what they said, but that's actually what happened. The idea was to save money, and what actually happened was they were just saying to each area around the country, you can have X number of nurses appointments advertised per week, and that is it. So if you had 80 staff vacancies in Northland, you would only be able to ever advertise 2. And that just means
Can you
that
say
all
that
of
again?
those.
Because I think that is contrary to almost everything that we read in the papers and hear from. First, it was Shane Retty, the health minister, but then it was Simeon Brown saying
Yeah,
that they've hired, thousands of nurses and record funding, and at times they've said there's overstaffing and this and that. But can you go back to that number of 80
yeah.
vacancies and
So
hiring 2?
this is just an example. This is a genuine example, but I can't tell you when that was. But I know one particular week there were 80 nursing vacancies across Northland to Fataora, and they are only allowed. And this is not coming from our general director; it's coming from a national level. They are only allowed to approve and advertise 2 per week. So there are numerous educators, senior nurse roles, floor nurses not even being advertised. And I think that's improved since this time last year. There's possibly a higher number that they're allowed to approve per week, but it's certainly not. Their staffing system, which I'm sure you know, is I don't know if you know much about the trained care system, but the system, their care capacity demand system, which is a government system that they support, shows very clearly where there's nurse vacancies and a lack of FTE in a department. They are supposed to then recruit to that FTE, which is their safety backup. But what's been happening is that the FTE will be calculated, the vacancies are clear, but they won't actually advertise or recruit into those vacancies. And that's deliberate. It's basically deliberate understaffing to save money. That's what they're doing.
And through it all, for the past 18 months, you hear the government politicians saying that there is no hiring freeze. You hear the higher up saying no hiring freeze. But for the people on the front line, we know that there's a hiring freeze. We can see it like with our own eyes every day, and the patients can feel it in terms of
Yeah,
delays, whether that's
absolutely.
in the waiting room or waiting for clinics or being on a list for a surgery. This understaffing has like real world consequences far
Yeah.
beyond just the staff.
Absolutely. And I think the other thing that they've been doing, which is which they've been trying to do to hide the understaffing, is that in the past, you would go to work, you would be expected to work in your area. If there were too many staff, very unusual, but if there were too many staff, it would just be a better day on the floor. Now you're expected, if you are overstaffed, to send your staff away to another area. Now, it's not that nurses are not willing to go and support other understaffed areas from time to time, and that's what is in our contract, from time to time. But basically at the moment, and since this time last year, they've been using nursing staff like chess pieces. So they have whoever turns up at work, they look at the areas, where are they more staff, where are they less staff, where can they really not leave an area with a gap, and they will move a nurse to wherever they think they need to go. And this means the reason that's a problem is because, well, firstly, obviously nurses hate being moved all the time, but the main issue is actually a safety issue. So we have ICU nurse being sent to work in mental health, we have an AU nurse being sent to work with children who've never worked with children. We have nurses moving all over
Wow,
the place, very unsettled, very unstable, and very unsafe.
that's wild.
Yeah.
Um,
And it's
I don't
causing a huge
think
number of sick calls, which they are very unhappy about, but they don't seem to understand that actually by not supporting the nursing staff in the areas that they have been contracted to work in, then they are probably creating more sick calls because staff are really unhappy, burnt out, and feeling very unsafe being sent to areas that they just don't know.
I think
Which is obviously a patient issue. I mean, it's a patient safety issue. It's not just a staff safety issue. It's a huge patient safety issue. I mean, if you sent me from ED to a medical stroke ward, I would I'd be running by the skin of my teeth. I'd be
Sure.
happy to do it, but I wouldn't know what I was doing really.
Sure, sure. And I think there's a critical mass when you get too many people in a department that aren't from that department, aren't used to it, or are just newcomers. That's a real issue. So one of the solutions government has been talking about has been to import more nurses. And one of the problems that you face is not having enough sort of older, more experienced local staff to be able to onboard these people and acclimate them to the system and bring them up to speed. So it's quite haphazard. It's like putting patches on a wall that's about to cave in, and you're just sitting there, patching small leaks.
Yeah, I mean, I
Can
think
you talk?
one of the issues with the senior staff is that they haven't really done anything to retain or recruit senior staff. And obviously, when you move to a senior staff day role, you're not going to be working nights and weekends, and so your pay will drop as an overall daily pay. However, you are taking on a huge number of responsibilities. You're often working late. You're often not getting a lunch break. You're often
Sure.
taking a big responsibility, as you say, for training and educating new and overseas staff. And so, as it stands at the moment, the senior pay does not reflect that. And we were told that would be sorted out in the last bargaining, which I was also part of. And a senior nurse working group was created. And there was an understanding by the senior nurses that there would be some adjustment to reflect those senior responsibilities. Because at the moment, if you're a senior nurse, you probably get about 50 cents an hour more than the nurses that you're managing.
Sure.
So
Now,
that's an issue, but also the other thing that you talked about is that they've made a promise. They made a promise to support the workforce being trained in New Zealand and support new nurses, and they absolutely haven't done that. They haven't agreed to train and recruit all new graduates. So there is no incentive at the moment for somebody to go into nursing not knowing whether they're going to have a job at the end of it.
it's pretty bleak. Where do you see this going over the next 18 months? What's your impression of what will actually happen? And then where do you think it needs to go?
Well, as a bargaining team, we've probably done as much as we can. There's only 10 of us. We've done what we can in the last 16 sessions we've had with Fatora, and we basically need the rest of the nursing organisation members to stand up and say that they're not going to put up with this any longer. So that's what we've asked of our members. We've been having stop work meetings this week to discuss strike action, and the plan is to have a 24-hour strike. There isn't a date set. And then after that, there will be rolling strikes of some kind.
Wow. That's a drastic step, not only because of the impact on staff and patients, but also the impact on the strikers, I guess, give up their pay during that time, right? So there's a financial impact on the people doing the strike. There's obviously going to be impacts on staff and patients and everything else. And through all of this, there doesn't really seem to be, in my opinion, an acknowledgement by government of just how serious the problems are. So they seem to think that these shortages, for example, or these hiring freezes that they refuse to call hiring freezes, are kind of minor inconveniences. Do you have an idea about what the actual number of unfilled roles are or understaffing is in the country? And
No,
also, can you talk about how that number is calculated? Because it seems like every group has a different guesstimate of what that number is.
I don't think they need to guesstimate. It's pretty clear, and that's why the care capacity demand management system's in place. So I don't know what the total number is over the nation, but I could probably try and find out. The FTE calcs are done yearly, and that not everybody does those calculations because there are areas where it doesn't work, but the FTE calcs are done, and it's very clear where the gaps are, and they're certainly not being recruited into. So I can't see that the staffing crisis is going to get any better. I mean, we had our own staffing crisis in ED a couple of years ago, and from what I can tell from around the country, speaking to people around the country, that kind of crisis is happening everywhere, and they're just really trying to squeeze patients in, whether there's staff or not. Even, you know, where we work in Whangarei Hospital, I've had delegates ring me up in tears because their nurses are just not coping with the levels of patients they're expected to care for. If they don't have the staffing and they don't have the backup to support the wards, they just push more patients into the wards and expect you to look after 8 to 10 patients overnight, which is absolutely not safe. And eventually it's going to
sometimes
overseas, which is not what we want.
Sometimes not even into beds upstairs, sometimes into hallway beds. And, you know, there are patients in corridors, there are patients sitting on plastic chairs, there are patients in the waiting room being looked at by triage nurses who now have this added responsibility.
Yeah, absolutely. And there are patients on the wards in supposed contingency beds, which are actually a cupboard and don't necessarily even have oxygen or suction. So that's the reality.
Can you tell me what a contingency bed means? Is it a real bed? What is it supposed to be?
It is a bed, but it's a physical bed. It basically means when the ward's full and ED's full and they desperately need to send another patient to the ward, but they don't have any space, each ward has an extra bed, which they use in emergencies. And some of those beds are either in a corridor or a cupboard, and they're cared for by the same nurses. There's not any more resource put into the ward for those patients.
Wow. All right. That's I think that's more than enough for someone to try to digest. That sounds bleak. That sounds very bleak, but I thank you for delivering the news. I mean, I feel sorry for all of you that you've had to go through 16 meetings and not come out with something tangible. And I think it's interesting to note that 1%, right now inflation is running around 2.2 to 2.5%. So that 1% pay offer is not in addition to inflation. It is well below inflation. So essentially, this is it's a real terms pay cut, isn't it?
It's a pay cut. It's essentially taking a pay cut, and there's no back pay, so it will be essentially 0.5% this year and 1% next year. And with pay equity thrown out the window by Brooke Van Velden, there'll be no pay equity reviews, which means if this carries on, the wages will just slip back and back and back, and we'll be back to earning terrible wages again in a few years' time. So that's why it's so important. We can't just say, oh, sorry, you know, the poor government, they can't afford it this time, let's wait till next time. There's just, you know, if you're going to take a pay cut, that's a serious thing to consider, and we shouldn't be accepting that.
And on that note, we'll end it. Rachel, thank you for your time. I appreciate you for coming on the front line and talking about the challenges that nurses face in New Zealand.
No worries. Thanks for inviting me again. See you.
You're welcome.
Bye-bye.
Bye. So don't log off yet, Rachel. You still there?
Yeah, still here.
Good. That was superb, I think. That was 20 minutes, and you covered a lot of stuff that you can't just get out in a soundbite. So that's awesome. You're really, really, really good. I'd like to do a second segment now, if you have the time. Do you have 10 minutes?
Yeah, sure, yeah.
We're already here, and we went through all this stuff. So I'm just going to reintroduce you, and I'd like to talk about some of the issues that came up when I browsed the New Zealand Nurses Organization website. It talked about.
I know what they are. You have to tell me.
No, well, I'll ask you if you have heard anything about this. 370 perioperative nurses having to do involuntary overtime in Auckland City Hospital, Green Lane, and Starship due to chronic short staffing, and they've done a month-long on-call strike. I mean, do you know anything about that?
I don't know the details. I could.
Is it really involuntary overtime? Sounds like.
It's something to do with it. I actually don't know much about it. Hang on.
That's fine. We won't have you talk about to that then. All right.
I do know somebody who could talk to you about that, though, who's actually is an Auckland perioperative nurse. It's to do with I think I might not
just
be
have them contact me if you want, and we can do a 10-minute informational session on that. Are you able to speak a little bit to pay equity? I mean, I obviously can as well, but
Yeah.
it affects Plunkett nurses, community nurses, aged residential care workers, and 16 other groups.
Hospice.
150,000 people affected nationwide. So, do you want to speak to that a little bit? Do you feel comfortable talking about how pay equity has been bad?
Sure.
Okay, so maybe um, that will be a good thing to talk about. Is there anything else that is sort of catches your fancy that you want to talk about that's a bit different than what we covered? So we'll just have a little snippet on pay equity.
Not specifically, I don't think, because we talked about safe staffing. That's probably one of the main things.
Yep.
Yeah, probably not specifically at the moment.
No, that's
I
good.
mean,
I think pay equity deserves its own little segment because
yeah, I think
essentially
so.
they fucked over so many low
Yeah,
wage women in the country
yeah,
that it's
yeah,
really it's unprecedented. It's like it's a step backwards for
yeah,
hundreds of thousands of families. Alrighty,
absolutely.
so we'll start up again, and I'll just have you introduce yourself again if
Yeah,
you don't mind. Hi, Rachel. Thank you for joining me on the front line. Thanks for coming on today and being willing to speak about pay equity. So, can you just introduce yourself, and then if you want to get into the pay equity discussion, that would be great.
sure. My name is Rachel Thorn. I work in Whangarei ED as an RN, ACNM, and clinical nurse coordinator. I'm a New Zealand Nurses Organisation delegate for the area and the co-convener for Northland, as well as currently being on the bargaining team for the contract. So, yes, pay equity. What I would like to say to Brooke Van Velden, that is a real step back for women. And to be honest, men should be paying attention because there are a lot of male nurses and they're going to be in the same position. So it's not just about women, it's about everybody who work in health and haven't yet got their pay equity, as well as the people who have already been given pay equity. There are no current reviews coming up, and that has been scrapped. So basically what's happened is they've suddenly decided that pay equity was costing them too much money, despite the fact that this is a process that started years and years ago and the money was put aside at that point. So I'm not sure what they did with the money in the meantime, but that should never have been an issue for managing the pay equity budget. So in effect, they have just decided that really, well, the impression is that they didn't really think that we should have got pay equity and that the people who had the pay equity maybe got too much. And therefore, as a result, we've cost them too much money. And so they want to stop the pay equity processes for those who have already put claims in. So I think from memory, there was about 30 claims for pay equity already in process. 10 of those were through the New Zealand Nurses Organisation, and that includes for nurses such as hospice nurses, Plunkett nurses, community nurses, and many other job areas. So those claims were already in progress, and they have essentially been scrapped and told that they must reapply. In the meantime, they've changed the criteria. So the original criteria was that you had to have, I'm pretty sure, 50% of your nurses needed to be female. And now they've put it up to 60. It's either 50 and 60 or 60 and 70. I can't actually remember, sorry.
I believe it's 60 and 70. Yeah, they've
Yeah,
raised the bar to
they
a
raised,
level that most groups
which means
can't
most
reach.
can't reapply now. So they've essentially scrapped pay equity for most of those groups, which is pretty shocking, pretty last century. And I'm extremely disappointed that a woman who's headed this has said that this is an okay thing to do, especially somebody who, I think her comment when somebody asked her how she felt that this was an okay thing for women in New Zealand, she said, because I am a woman and I support women to work, which is a ridiculous thing to say and doesn't indicate in any way that she supports pay equity, because she is a woman and yes, she works, but she earns 270 something thousand and is about to get a $20,000 pay increase. So I don't think anyone in that position is able to understand or comment on whether pay equity changes are going to affect women.
Yeah, they really live in a world of their own. Simeon Brown attacked doctors for make public doctors, so not private ones, but just the public ones that are salaried, paid according to the SECA pay scale. He attacked them for being paid too much. And you think about what he contributes to society. The
Hmm.
man's raking in a pay package of somewhere in the mid 400,000s
Yeah.
when you add up all his perks and bonuses, and something like, correct me if I'm wrong, viewers, but I've looked this up a couple of times now. Matching like superannuation, pension matches up to like 20%. So these people are getting pay rises that are written into legislation like that will there's no negotiating, right? Your group had to meet 16 times to beg for a 1% pay rise that's less than half of what inflation is. And these politicians are living in their own world where their pay rises are vast.
Yeah.
And a story just came out a couple days ago that they got their own private pub in Parliament. So if there's any idea that anyone's out of touch in this, our politicians are so out of touch. And it makes sense that Van Velden would say she supports this.
I
She
mean, I
will
think the other
she
part of
will
it
not
is
be
that
hurt by any of it.
no, she's not going to be hurt by any of it. And it also shows a complete lack of understanding of what equity is versus equality. Because one of the comments she made was that she wasn't against pay equity, but she was still going to support that women were paid the same amount as men in the same profession. What she didn't like was that different professions were being compared to other professions. Well, if you understand equity, that's what that means. Women, women jobs where women are a high percentage should be being paid the same rate as other jobs which are similar, but have men as a high percentage. I mean, that's what equity is. She's talking about something that's equality within a workplace, and that's actually not the same thing, which just shows her complete lack of understanding of the whole situation.
They don't understand because they don't need to understand. And beyond that, they don't really care. I mean, you asked, like, you said something like, what did they do with the money, right? The money that they needed to get out of the pay equity by canceling the pay equity claims. They've spent that money last year, right? Under urgency, they gave $216 million to a tobacco company to help them sell more heated tobacco products. They're giving 200 million to gas and oil companies to help them drill to offset their costs, because if you're a rich gas and oil company, you need a little bit of taxpayer money to the tune of 200 million to help you through these challenging times and the cost of living crisis. So it's pretty awful. And then we won't even go into the whole property investor thing with landlords getting 2.9 billion. I mean, that's enough money to correct every nurse and doctor shortage in the nation and provide free dental care, public dental care for every citizen. So, yeah, that's where the money went. The money got spent last budget, and now they're just looking for ways to claw it back
Yep.
from the most vulnerable people. So, the people with
Yeah.
the least voice. And when I went back and looked at some of what these pay claims, that the pay equity claims that went through they were the win was the ability to get $2 to $4 more per hour in recognition that your profession is historically underpaid because it's female. So
Yeah.
these women just wanted the chance to argue their case in court and just say, like, have a good look at this. Is it's manifestly unfair? Do you agree with me? Have a look and then fix it. And the fixes, when they were supported, were small, but they wouldn't even allow that. So this government has essentially put the boot to 150,000 low-wage women with
Yeah.
no remorse whatsoever.
No, I don't think they care. I think they were so shocked to find out, well, maybe they weren't shocked, but they apparently were shocked to find out how underpaid women were. And instead of thinking, this is terrible and we'll address this immediately, they thought, oh, well, how can we save some money? We'll just scrap all the rest of the claims, which is pretty disgusting.
Yeah, and can you elaborate on, like, no future reviews? What that means?
I think that basically means that when we first got pay equity within the hospital nursing staff, the plan was to have a review, and I'm sorry, I can't remember exactly how often the reviews happen, but I know one should have happened already by now.
Hmm.
So that was to ensure that the places where pay equity had been put in place didn't fall behind, and that was supposed to be on a regular basis. Now they've scrapped all the reviews, so essentially, although pay equities happened, any increases will have to happen through bargaining, which, as we can see this time, is not necessarily that easy. And so instead of having a review at any point in the future, if we feel in 10 years' time that our pay has fallen behind again, which at this rate it might well, we will have to go through the whole pay equity process again. And with the new criteria, it's possible that that would not happen. So it's essentially a way of disabling us from keeping up with any other profession except through bargaining.
That's just awful. That's corrosive. When I was looking at how,
no, so go
sorry,
ahead.
go ahead.
Yeah.
When I
No,
was
it's okay.
looking at how, trying to figure out how they came up with the 70% in terms of this new criteria that you've got to meet instead of the 60, it's pretty obvious that a lot of these women predominant professions had percentages in the 60s, 63%, 66%, 67%. And what you could do by drawing a line at 70, you could just eliminate so many of them summarily.
Yep.
And it's deeply cynical. It's essentially throwing people off of the boat and then pulling up the ladder just a little bit higher so they can't reach, like ensuring that they can't reach. And they're not saying, oh, we got rid of pay equity. No, you haven't gotten rid of it. You've just made it unattainable for most.
Yeah.
Deeply
Basically,
cynical.
well, absolutely intentional, like the intentional understaffing. They're intentionally removing the ability of people to apply for pay equity, which in this day and age is just not okay.
It's probably worth mentioning that the pay equity thing did not only apply to nurses in healthcare. It was plunket nurses, community nurses, aged residential care, and like 20 other groups. Also probation officers, also literally tens and tens of thousands of teachers, early childhood education, many sectors across society are affected, and being set back. And
I
it's
think
just
that shows their their lack of respect for early childhood teaching. I mean, do they really care about the education of our young children? Do they care about hospice patients? I mean, that's what we're talking about. If you underpay staff, you're not going to retain those staff. You're not going to get people coming into those professions. And therefore, the people that suffer in the end are the patients, the children, the prisoners, whoever it is that's affected on the front line as a result.
Absolutely. Yeah, I think there's sort of an under theme under all of this, an undercurrent, that they will do things, this current government will do things that tend to benefit corporate profits and sort of multinationals. So whether it's school lunches or things to do with pay equity or nursing or teaching, or the privatization of 10,000 surgical cases, putting them out in private hospitals. Like under it all, you've got to ask yourself the question of, like, if you wonder why bad things are happening and government seems to not care about it, just ask yourself who is profiting, who is thriving off of this. And more often than not, there's a corporate behind that, and that they're doing very well, whether it's teleradiology, telehealth, private hospitals, which are absolutely booming. So last week, Mercy Ascot announced their $190 million expansion. These folks in private know that the money is coming their way, that there is a hollowing out of the public sector, and it goes across all the professions. And it's up to, I guess, people like you and me to try to at least speak to it and say, hey, guys, look, there's this thing going on. If you could have a message for regular folks, just viewers out there, patients, normal folks, what would it be regarding the pay equity stuff that they read in the papers versus what you think the real message is that they should know?
I think the public are actually very supportive of pay equity. I think the public see staff running around in the hospital. They see how stretched the community staff are. They see how stretched people are, how tired they are, and how much they work, and how they still commit to the job that they're doing. And I think that, you know, there isn't any question that women heavy jobs should get pay equity. So I guess, you know, what can you do? Write to Brooke Van Velden. um, I don't know. I don't think it's really a question. I just think I think it's just this government. They're entitled. They'll do whatever they want. They just want to save money. I totally agree about the private. I guess I would say be very wary of the private system. It's a very slippery slope going, like making private systems part of our public system. I think it sounds very nice. You might get some good meals in a private hospital, but the reality is you're stripping out the public service by doing so. And in the end, if things go wrong, it comes back to the public service anyway. So, you know, I think that's my take-home message about the public private merging that's going on, is that it's not, you know, when it's not just a case of paying private hospitals to do the work that the public hospitals don't have time for. By doing that, you're taking resource away from public hospitals, you're taking doctors and nurses away from public hospitals, and in the end it's going to be a very messy downhill slide. And having come from the UK, where the NHS is very much using that model, it's not pretty.
Yeah, I mean, the worldwide experience for private equity owning your healthcare, like a perfect example of that is the government's giving 50 million to urgent cares to quote unquote take the pressure off of our emergency departments. What they're doing is giving these multi-million-dollar contracts to private equity corporations centered in Sydney, you know, who run White Cross, who pocket
Yeah.
some of the profits immediately, and who internationally have been shown to have worse outcomes than public systems. This is shown time and time and time again. Worse outcomes due to cost cutting and understaffing.
Yeah.
And of course, in New Zealand, you've got the additional thing of there's only a limited number of doctors and nurses here. So these privates, whether it's telehealth pulling GPs out of their jobs or private hospitals pulling surgeons and theater nurses out of their public hospital jobs, it's a one-way street. Like once you decimate the public system, it's not like they're going to come back from private into the public. The
No.
money is out there. The profitable, easy, simple, straightforward cases are predominantly being cherry picked in the private, and we're losing staff and we're losing training opportunities. So it's bad on many levels. And yeah, I hope people understand that the public hospital they return to a year from now is not going to be the same public hospital that they expected to have. And I think we're seeing it in primary care first, right? The absolute collapse of primary care and
Yeah.
GP practices in the country. Very, very bleak, but fixable. Like we have to, if we stop them from doing this, stop from making it worse over the next 18 months, at least there's a little hope that we can rebuild this over the course of the next 5 or 10 years. But I think if we do let it go on and don't put a stop to it, we're talking about decades long rebuilding of the public health system.
Yeah, I mean,
So yeah,
lack of GPs is a huge issue across, I think, across the country, but definitely up in Northland. I mean, I couldn't get a GP appointment for 3 months unless, you know, unless it was super urgent. So I think that's
well,
pretty common. I don't think it's that unusual. You know,
yeah.
that's why we see so many people turning up to ED. There just aren't enough GPs. The GPs aren't being well supported, and it's just not a desirable job to do anymore for a lot of doctors, and that's because of the lack of support from government, which is really sad because they're such a stalwarts of their local community. Very, very important, and very important for the health of local communities, particularly in rural areas. So yeah, I totally agree. I don't think private telehealth is the answer at all. There's nothing you can do on telehealth that can't be done better in person.
And I think one thing that will come out of all of this, these negative changes, is a unifying of GPs with hospital doctors, with nurses, with teachers, with police, with defense force. I mean, like you name it. Everyone who has to work serving the public in one capacity or another, in an essential public service is threatened under these sorts of governments. And I think we're seeing that right now. So thank you, Rachel, for the work you do, for the 16 contract negotiations that you've been to on behalf of your fellow nurses. And keep up the good work.
Thank you for inviting me. And I think it's really important that the different unions keep talking and that we work together to push the government to doing something more, because we probably can't do it alone. I think it's really timely that a lot of the contracts have come up at the same time. And so, we need to coordinate and push back as hard as we can.
We'll be out there with you.
Okay. Thank you, Gary.